Bismillah, hello everybody, and thank you for the organizer for giving us this opportunity. I just want to present a review article regarding surgical approaches for thoracic outlet syndrome. You know, thoracic outlet syndrome is a collection of disorders caused by compression of the neurovascular bundle while it is passing through the thoracic outlet. The treatment options remain controversial between the surgical intervention and conservative measures. Even the surgical intervention, there are several controversies regarding the approaches for thoracic outlet syndrome. This abstract will review the current literature regarding the surgical options for thoracic outlet syndrome. The study concentrated on the literature in the last 20 years. Just to be updated regarding the surgical approaches, the keyword involved in those keywords that related to the thoracic outlet syndrome surgical intervention. There are several surgical approaches. These include transaxillary approach, supraclavicular approach, combined approach, posterior approach, minimal invasive approach. Even minimal invasive approach, there are several procedures for minimal invasive approach. Just a few notes regarding each of them, how literature talks about them. Transaxillary approach, it is remain the commonest one because it's a cosmetically more acceptable, as you know, and there's a good surgical outcome. What we observed in the literature that almost all of the surgical outcome they have nearly the same clinical outcome, nearly the same. Clinically, they have the same outcome, really. For example, in this transaxillary approach, you have 90% improvement in more than 70%. The problem in the transaxillary is it's limited for the first cervical rib section and prolonged transverse process in the 7th rib. So in transaxillary approach, we don't have good access to the posterior part of the thoracic outlet. Regarding supraclavicular approach, it's very good for complex cases for cervical ribs, for prolonged transverse ribs. Nearly had the same outcome with the transaxillary approach, but it have the problem is cosmetic. So the long-standing problem of the supraclavicular approach is a cosmetic appearance. And also, it's mentioned that has a higher risk of nerve problems, neurovascular injury. We have infraclavicular approaches mostly used for venous thoracic outlet syndrome and for those also with the pectoralis minor syndrome. With a single incision, you can resect the anterior part of the thoracic outlet syndrome, thoracic outlet and the pectoralis minor also. For venous problem, it's reported to have 100% of success rate in the patency of axillary vein. The problem also we have limited access to the posterior compartment. Posterior approach, it was a classical incision for thoracic outlet syndrome, but still remain working for the recurrent thoracic outlet syndrome. Whenever recurrence happens, posterior approach is the most common one used for thoracic outlet syndrome. Of course, if you have venous problem, if you have anterior problems, it's difficult to manage. Combined approach is not infrequent in the management of thoracic outlet syndrome. Sometimes we need 2 incisions for complete decompression of the thoracic outlet. So obviously, it adds more time for the procedure. It's more invasive. It's lead to more postoperative pain. A minimal invasive method for thoracic outlet decompression also we'll find so many debates regarding the minimal invasive. Of the top for me really is that involvement in the pleural cavity. Thoracic outlet decompression by itself is a procedure outside pleural cavity. But in minimal invasive till now, we involve the pleura, and we usually do one lung ventilation This might be not so difficult or more morbidity for younger population, but still you have smokers in the younger population. They might have postoperative more complication. Of course, it will add, it is minimal invasive and a small incision, but the problem is involvement of the pleural cavity. In conclusion, surgical approach, surgical decompression remains the cornerstone for management of thoracic outlet syndrome, and the choice of the which procedure, which approach you will choose, it depends on anatomical anomalies and also depend on the surgical expertise. At the end, I want to invite all of you to our event in the April in Iraq. It's a 2-day activities specified for diagnosis, for management of thoracic outlet syndrome. In this event, we have tried to collect almost nearly all the expertise around the world regarding these symptoms, and it's a 2-day activities completely specified for thoracic outlet syndrome, and it involves multidisciplinary approaches. And thank you.
Thank you, Mr. Hussain. It's an interesting subject. It's complex as pathology. You have done the choice. Is there simple access to prefer in order to planify or predict one's second access in case of relapse of the toss?
Yes. Yes, you are right. Usually, for the recurrence toss, the posterior approach is the most common one used right now. But if you have if you've done a transaxillary approach, it's wiser to do supraclavicularly if you have a recurrence. If you have done supraclavicular approach, it's wiser to go transaxillary. So I agree with you totally. For the recurrence toss, I think it's better to go through a different pathway.
Because the problem is fibrosis.
Yes, you're right. Adhesion and fibrosis, yes.
It will be quite difficult to access. I open the floor for question.
Thank you very much for the nice overview. As you know, we do robotic approach. We published our first 30 cases, and I think once you saw the robotic approach, you don't want to do anything. You see exactly what you are doing.
Yes.
You see the vein expanding, you see the nerves which are basically far away, which you can control very nicely. And I think this will be the future for safety, also for safety reasons. And as a thoracic surgeon, I don't understand your argument very much involving thoracic cavities, involving the pleura.
Yes.
We involve the pleura every day. You know, we do biopsies and we involve the pleural cavity. We do mediastinal tumors. We involve the pleural cavity. Why not resect it?
Usually in other approach, most of the time, we don't open the pleura. We don't need single lung ventilation. We don't go through the pleural cavity. I heard someone one of the experts in the TOS management said it's an extra pleural operation. Why make it intrapleural operation?
We have to use the most secure approach, and we shouldn't let do plastic surgeons approach, which has much more complications and much more risks. And that's thoracic, where you see what you're doing, and for us,
yes. Okay. Really, we don't have a robot in our hospital, but that's a daily procedure. We'll try. Okay. Thank you.
Dr. Bay.
Thank you.
Just to